Welcome everyone to today's webinar, Breaking Down the Barriers, the Crossroads of Interoperability and Population Health, sponsored by Allscripts. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. At this time, I'm pleased to introduce today's speaker. With over 17 years of strategic healthcare IT experience, Michael McAfee is the Allscripts AVP of Interoperability and Population Health Solutions. Mike works closely with clients, providing guidance around their population health and value-based case initiatives, including technical architectures and efficiency models, which are adaptable regardless of regulations, future initiatives, or current IT ecosystem. At this time, I am pleased to turn the floor over to Mike to begin today's presentation.
Thank you so much, Ayla. I appreciate the introduction, and I also want to say thank you to the Becker's Health organization for affording us the ability to have this discussion here today. And I look forward to breaking down the barriers and talking about interoperability and the crossroads between that and population health. I think we have quite a long topic here. It's taking up many lines just in the introduction slide in order to talk about what is really an ever-present industry strategic goal, program, initiative, thought, need, all of the above for organizations across the entire healthcare economy. 17 years, it's been a long time that I've been doing this and really focused in on healthcare, and thankfully I don't have the webcam on the GoToMeeting here, or else you'd see the scars and loss of hair that creating these pathways, these bridges, and getting all of the governance and getting all of the folks together that really makes what ends up being a true value, a true, as I said earlier, the healthcare economy becoming this value-based ecosystem that can build and adapt based on the kinds of variable initiatives and programs and governance and regulatory requirements that each one of you have to tackle on a day-to-day basis. The real target of all of this is to try to identify strategies and pathways that can make things easier. As we know, for the folks who've done it, as I said, scars, loss of hair, folks burnout, all of these things that attribute to trying to provide the best quality care at the lowest possible cost is something that is very, very difficult. And what we've seen across the board in all of these different ecosystems in which as I saw the attendee list, in which we have all of these centuries of experience across the folks who are joining us here today on the webinar, it takes a true strategy, a true pathway, a true understanding of what your goals are, phased approaches, mission statements, and really teamwork and cross interdisciplinary teams to come together and build an ecosystem of growth. What we hear time and time again from these organizations that we work with, the folks who are, and it's a very, very, very varied, disparate ecosystem that's out there, and many organizations, many solutions, many programs use the same names to talk about different features and functionality. And it becomes very difficult for clients, for organizations out there to really figure out what is the right path forward. As we know, budgets, we know the staff proclivity to taking on new technologies are both pretty thin. A lot of folks are trying to do more with less because of the IT spends over the last number of years, meaningful use requirements and updating of hardware and folks moving to the cloud. that really the drive to try to explore new ideas for many organizations is very limited. Folks have to have a targeted approach to be able to solve for their requirements, their needs now, and have a pathway for the future down the line. So we're going to cover a number of these different topics, sort of baselining as we go between interoperability and population health. That's really been the focus of my career the entire time. The biggest benefit that I've had, and also caused the separate benefit of many airline frequent flyer miles, is I've had the benefit to work with a number of you across the not only within the U.S. I'm based out of Pittsburgh, Pennsylvania, where we're having one of our very rare sunny days, but also internationally. And you start to see trends emerge. The need to manage care for a patient across the entire ecosystem, where the right people are doing the right action at the right time for the right patient. And within those rights is a standard, is a process, is a regulation, is a belief and a need to be able to ensure that you're doing that right action and that you won't go broke for it. So I often talk about, and you'll hear some of this, is trying to maintain that equilibrium between doing what's right and what's needed at that point in time and ensuring that it fits within your regulatory and payment models. It's a very difficult avenue to go down. And I could stand here and talk about some of these credentials, being able to go out and talk about how interoperable that we really are, and what the vendors are out there. Every vendor that's out there all touts APIs. They all talk about FHIR. They all talk about data shares and utilization points, but it's not the why. It's those are the things. Those are the abilities. It's not necessarily the why or something at the end of the day that you, as the organizations that are out there, you have jobs to be done, and it's been a lot of them morphing and trying to throw technology out the window, or really getting to that why. The first is the what. What is interoperability? It's very difficult, or I should say it's either very difficult or very easy to define. Often these organizations, or often the market, tries to dictate and say this is what interoperability is. There's very varied definitions that are out there, but some of the measuring organizations, marketing analysts, business analysts, and industry insiders would often say that interoperability is the access to external information within the workflow. And often it's provided as part of the very low common denominator of documents, querying out via a number of different technology acronym soup, like you see here, via IHE with XDSB, XCA, XDR, all of these different avenues to pull information from different places. The need to connect out to regional, state, VA, eHealth, Commonwealth, care quality, and then leveraging things like the connectathons and interoperability to showcase to ensure that the solution you're using to connect out to these entities is the right avenue, and it fits within your regulatory needs for meaningful use, or even the CMS, ONC, and CDIS initiatives that are out there, all within high tech. It's acronym soup. It's whenever spoken about that way it's overwhelming. And whenever you're trying to really tackle what it is well, what do you really need interoperability for? Are you trying to check a box, or are you trying to actually do something that benefits the quality and the cost that it takes to manage your patients? Often we hear about FHIR being the next evolution in the cleaning up of this acronym soup, with creating the fast healthcare interoperability resource. And it's something that has a great promise that many vendors, ourselves included, are investing a lot of time, effort, and investment in order to create not just a technology, but a solution, a leverage point. What is it that you need to do at the right time to do it? And often, as we start to talk about all of these different areas, many of them have been around for a long, long time. And it's kind of interesting, well, maybe not so interesting, but it is something that, as per today's terms, in my career, when I first started off, I was an interface developer who was tasked with creating interfaces between flow cytometers for cellular immunology. So those systems which measure and report on the leukemia and HIV being seen within blood samples. And the goal of that was to be able to reduce or eliminate the manual entry of information, one from the LIS to identify what tests need to be run on a blood sample, two, what work needs to be done to enter that work list, enter that blood sample into a work list for the machine, then take the results from that machine and then submit them right back to the laboratory information system. The products, the program, the solution that we came to back then was something that was very advanced for the clinicians. And it's mainly because we focused on what was the job to be done. The job to be done was to enable a clinician, a med tech, to be able to rapidly and safely manage HIV and leukemia lymphoma blood samples so that you could tell very quickly what tests needed to be run on it. You didn't have to touch a keyboard, and you didn't have to manipulate any of the blood in order to have the machine run, accept the results, map the results to another language, another terminology, and have it submitted back to the LIS. And it ultimately ended up saving 6 to 8 hours every day of extra documentation, hands-on keyboards. Who would have known back then, 17, actually it's now closer to 18 years ago, that would have been advanced interoperability. That was semantic normalization, as we were doing mapping. We were doing a lot of these things when really all that we were doing was targeting what's the job to be done. And that's where we start to say, well, how do we start to simplify this? We see the industry start to say, well, if we're operating under that earlier definition, that earlier example of access to external documents that were created outside of my environment so that I can leverage them within my workflow for this patient or patients that I need to act on. There's different levels of interoperability. There's the interfacing, being able to exchange data. Often this was focused on HL7 and X12. Integration, leveraging pulls or pushes or vendor-driven APIs, was trying to get into that deeper level API, which is interesting because FHIR starts to bring this around. This was earlier, or I should say later in the 2000s, early 2010s. Many vendors had APIs that were available, but they were customized, they were proprietary. Then as we get out to what is currently requirements from a technology perspective within interoperability, you want to be able to create multi-vendor, multi-organization, really standardized approaches to being able to access that information. Examples have been Direct, FHIR, Care Quality, Commonwealth, HL7, V3, and depends as you go domestic to international, the proclivity of all of these. And what is interesting is you start to go down these levels, you're still talking technology. It's not necessarily the job to be done. And the government, as we've had come out with the CMS ONC proposed interoperability roles, has really started to try to say, let me try to clean this up for you a bit. Let me start to try and create these conditions of certification so that I can ensure that an organization, a vendor, a system can be deemed as interoperable. Let me start to take the inroads so that we can start to tackle the jobs that need to be done. And as we get into more of this, it's starting to step into the world of population health. And that's really targeting is, I need to have access to the information. If you think about population health, what are the needs of population health? The needs are, I need to have access to the information. I need to be able to analyze or report on, identify cohorts. Am I managing risk or am I managing for quality? Am I identifying patients that need to have something managed? Once I have that, I then need to identify care coordination, and then I need to leverage that care coordination to either tell somebody to manage the patient a bit differently or provide outreach to that patient to do something for themselves. And as you start to step into those 4 levels, It starts with having access to the information, being able to ensure that as that patient's traversing across your network, that those clinicians, those users are really interacting with the patient with all of the information that is required to help manage that patient at that point, thereby building up your access, the more data component to this. So within CMS and ONC interoperability roles, you're going to have conditions of certification that these vendors are going to have to make just to say, I am considered interoperable. It starts to create that foundational, lowest common denominator across all those different avenues that you saw on the previous slide. And then have an avenue for real-world testing and attestations so that you can actually show that you're meeting the job to be done. You're leveraging APIs, you're leveraging the communications and insurances, all those building blocks to get to a point where you're able to have access to the information and leverage it in a way that in the future you'll have to report on. You need to have access to the data. So what data? The CMS and ONC has created a common data for interoperability, USCDI V1. You can see some of those areas that are new, and this starts to build out, and for those folks that are interested in, many years ago, the Journal of American Medical Associates created something called their tapestry, the JAMA tapestry. It's really talking about what data goes into the management of a person, not necessarily just a patient is a person, but all those ancillary, socioeconomic, the behavioral, but as well as their social media feeds, your the social care, behavioral, all of these areas that go and wrap around the patient, grocery, anything that that goes into who you are as a person is important in order to measure and understand. This is one of those first steps to be able to start to target some of those additional elements. It's not just the EMR, which is typically, or within the acute space, which is typically what the blue areas are targeting and capturing. You're having some information that's coming in as part of the encounter. It's being captured inside of the EMR. But then in order to be able to report on it and identify quality, and identify programs, and identify who's actually managing these patients, you start to identify the cross-organization clinical notes, procedure or progress, pathology, laboratory, imaging, all these areas that really a lot of the key data is found in. We'll talk about, maybe it's for another presentation, but across the board being able to have an understanding of who the patient is, a lot of data, as we know, is locked in here. And there's some solutions out there that unlock this as part of their interoperability solution and platform, enabling organizations to search deep within the clinical notes, even though they may be unstructured. Then being able to add the address, phone number, and importantly, I can tell you that not only within pediatric, but of all the data that was added and some of the requirements that are part of USCDI, one is provenance. Being able to target and identify who was the actual original author and when this information at a data element level was captured unlocks the potential for the true reporting, true assignment, and true understanding for compliance as to who did what for a patient. These levels, these integration, or I should say this data capture, helps with the building blocks of what are the jobs to be done. The jobs to be done within population health is to be able to manage and identify these cohorts of patients and ensure that what needed to happen did happen. This helps a great deal in understanding that level of information. Trying to reverse engineer this after the fact is a very Herculean task, and I think I lost even more hair off of trying to do that. What that enables you to do is to build upon the strategic interoperability framework. There's often this syntactic. Anybody who's passed information from one point to another, whether you're connected out to care, quality, common, well, HL7.2.x, HL7.3, fire, or what have you, you need to be able to have some level in which to pull information out of higher level architectures or structures. And then being able to say, well, once I do that, if I'm truly interoperable, I'm connecting to multiple different systems. As we see across the ecosystem, We see it more and more and more. The reach out, and we'll talk a bit about this as we go on for the organizations. You're trying to create a future-proof environment. You know that you're going to be, as you're making decisions as to what levels of interoperability you need to actually achieve with specific organizations. If you as an organization are looking to have an understanding of what's happening with your patient as they're going across the nation, here in Western Pennsylvania, most of our parents and grandparents live in Florida for the winters. I wish I could join them. But during that time, it creates a donut hole of data for the healthcare systems here, because they go down and access, whether it's in Orlando or Sarasota or in Tampa or Key West or where have you, they're getting care provided for for themselves down there. And that information is locked in those EMRs without systems like Commonwealth and Care Quality to provide that access point. It becomes very difficult to collect that information, because often you would need point-to-point interfaces to try to capture that information. But then as organizations start to really noticeably refine their strategies and start to focus closer and closer, and we'll talk a bit about this, your needs of the information, your needs of the integration require much more levels of rigor. Because as you start to look at your, maybe it's not just national, being able to connect out to national networks, you actually need to create regional ones, because your patients are going across a varied network and you want to rope in that network to send their patients to you. You want to make it so that you're a highly interoperable organization, so that makes it highly enticing for those practices out across that community to send their patients to you. So you want to create a level of integration that requires semantic interoperability. Being able to understand that all those different systems that you're connecting to call the same data by different names. And as the standards advance and change, we're seeing that be a very slow uptick to being able to create national nomenclatures that are used to document within those patients' records. So as you want to capture and tell an organization, yeah, your patient has diabetes, and you may be diagnosing with specific specificity, while those organizations may not, you don't want to just create lists and lists and lists of data. You want to be able to create a true framework of understanding of what's happening with that patient, so that you can leverage it and not have duplicity, duplicative information, and you notify organizations when certain things happen within certain hierarchies. That gets us to process. So one, if we have the information and we can understand it, we then want to start to build smart ecosystems. Smart healthcare systems where the right actions take place on the right patients at the right time. This level, as you can see, the difficulty to achieve, but it's the highest level of usefulness. This is where the more advanced ACOs, this is where the more advanced interoperable internal and external networks are really delivering key values now, so that the clinicians are told what they don't know without having to ask for it, and they're focused in on, are there notifications, are there certain items that are happening or should have happened for the patient right now that I was unaware of, and let me take action. Regardless of what EMR that I'm on, I can, as an organization, as an ecosystem, make decisions that says anywhere a patient presents within our ecosystem of multi-EMRs, even on the same EMR, is handled identically, so that we don't spend time doing trial and error. So we have all of these tools. We have this framework that has been built. We have the regulation. We have the industry and government that's stepping in domestically and internationally, focusing around fire and others. This comes down for you as an organization, but why? I have this kind of discussion with a lot of our organizations inside of our client base, as well as outside, is often it's a very technical conversation. And it's my least favorite conversation to have, or maybe my favorite, I don't know. It's I enjoy going technical, but it's not one that the organizations want to focus in on anymore. They want to be able to solve for a job, and sometimes it gets spun around vendor speak, or industry speak, or interoperability speak, and saying, well, I'm considered interoperable if I connect to Care Quality or Commonwealth, or if you support fire, that will solve everything that I need. And so often I work with these organizations, we work with these organizations, and the leaders out across the interoperability space say, okay, I'm going to snap my fingers and you instantly have everything that was on those previous slides. You have access, you have content, you have ability to all of this information, but why? What is it that you're looking to do? And over again, these organizations are looking to deliver a closed-loop healthcare platform. They're looking to drive and strive for better outcomes and drive process interoperability that allows you to really revolve around the patient, regardless of where the patient goes. And I hear this from organizations more and more, is help me negotiate, not necessarily manage. Help me, manage is for sure, but help me negotiate my payment contracts, my risk-based programs, my value-based care initiatives. Help me negotiate those things. So one, I can ensure that I am taking on the right level of risk, that I can actually ensure that I meet within that contract that I'm negotiating, and then deploy an ecosystem of connectivity, of value, and utilization and adoption. Those are topics that we'll hit here as well. That is something that is deployable and reactionary out across that entire ecosystem. So this is, now that I have this thought, this is that engagement that we have with these organizations that say, well, how do we do this? Well, to have access to that information, that collection, you have aggregation and normalization, which drives into a complete understanding of that patient. Having that understanding of vocabulary and normalization is going beyond. This is how you go beyond the point-to-point connections that happen within what traditional interoperability has been locked in. As you start to go down these paths, it's often around the transition of care, passing information, data or information as it becomes more advanced from one point to the next. This starts to become a process-driven organization where you're understanding what's happening with the patient from across all of these various ecosystems. You're building cohorts, you're identifying collaborative care planning, who's members of the care team, identifying, did the patient actually do what was supposed to have been done? Is there analysis or what has happened? If they did what was supposed to have been done, do we need to intervene? Do we need to step in again? Did they have another comorbidity that's been added, or can we reduce the medications that are targeted for this patient? Do they need to have so many active ingredients that are being utilized within this patient, within this population, and within this provider group, as well as across the entire enterprise? How are the patients being engaged? Are we telling the patients what to do and missing out on whether or not they've actually done it? This is what is a big avenue as these organizations start to step in. You start to build these layers, and as you start to step through the layers, there's a false sense of being done. Are you done whenever you handle a transition of care? Are you done whenever you connect out to the interoperability network, to Commonwealths and care qualities? Are you done whenever you do a report on your payer population to see what gaps are missing from whenever that patient was at one of your facilities? Are you done whenever you have a care navigator that is actually managing your patients, so you're driving your costs downstream, so it's not you as a healthcare system, it's not you as an organization, or you as a provider, or you as a care navigator? Are you done, or aren't you done, until you understand that the patient has actually made a change in lifestyle, a change in behavior, or actually is doing what is required of them or expected of them to be compliant with their care navigation plan? Or they don't fall inside of one of those plans and they're doing what's compliant for them as a person. I'm a 40-year-old male that needs to have his physical every year. Am I actually doing it so that I can be pre-screened and have my regular routine checkups and screenings that fit in line with the overall care management for myself, so that there isn't a time delay on any of these things and waiting until something really truly goes wrong? You need to have this vision. This is what organizations out there really expect from and really want to drive, as we've seen it, and we've worked with organizations out there like yourselves. This was something that was one of the high points of my career, and something that I'm looking forward to again at the Becker's roundtable that we host. This will be the second year in a row. Is discussion on interoperability, getting to the whys. What is it that means something to you? And as we see in the top right-hand side, hopefully this is coming through okay on your phone here or on your screen, depending on where you're accessing this presentation or listening later, possibly as a recorded event. The number one reason that came out of this roundtable as to what do you currently define as interoperability? It's managing patient populations, across clinically integrated network, an ACO or an HIE. And it wasn't necessarily just having access to external clinical information. It wasn't just enabling efficiencies from internal processes. You can see both of those had very strong engagements, and these are from folks across the board, large organizations down to multi-specialty and single specialty physician groups. These needs exist out across the entire ecosystem. And whenever you see what's happening here is, in order to do that, if that's the goal, if that's one of the major goals, is to be able to manage populations, primary concerns with the data is you have data quality and trust concerns. So you see how the industry has started to try to simplify, started to try to bring that common data for interoperability structure into place. But it still requires, it's a hybrid environment. This information that's coming from these different areas, all of it's being called, the same data is called by different names, same patients called by different identities, and building that aggregation, that level of interoperability is one of those ways that helps organizations meet their goals. And you can't do everything for everyone, but it helps these organizations really tackle and align for what's next. What are their main jobs to be done? We see it seems to be a reoccurring theme. If you've gone through organizational transition, because we've seen a lot of that over the last number of years, we're seeing it slow down a bit, but that's often where interoperability starts to pop up, is during that migration, during that change, whether you're acquiring new organizations, which we've seen out across the board, or you're being acquired, data migration. Those are the complaints that come in from the clinicians. Those are the complaints that come in from the data informaticists. It's not just interoperability. It's having access to that information. And the reality of this is because as you start to say, well, what am I doing? If that's really what my need is, to be able to manage all of these patients and populations, whether it's for a risk-based contract or quality, or just to have access, logical access to information at the point of care, these feeds are going all over the place. And trying to make a decision as to how to change and adapt is very, very difficult, because we as organizations that are out across this ecosystem have lived through MU1, having information pass from one point to another, the transitions of care, multiple different formats, feed types, direct messaging, CCDA passing, CCD, CCR, flat file, all these different ways to tell somebody something about the patient as they were inside of your organization. MU2 required us to have patient portals to get the patient involved and have access to their record so that we can start to build this on. But us as patients, I know myself, I have 5 different patient portals because my owned organization is different than the multiple different specialties that I go to, even though they're all under the same umbrella. They use different EHRs and they each have different patient portals. So in order to stay certified, that was that tethered patient portal integration. Then being able to complement, being able to have access to information, whether that's going through those state or regional initiatives, or you create your own private interoperability or HIE. It's often an out-of-band connectivity. Then, as you then start to say, all right, so if that's my workflow, that's my interoperability, that's my MU2, then as I start to get into MU3 and other initiatives, being able to actually manage and go through care navigation, where folks have really started to it's been great seeing this, actually, honestly, in the last 18 months especially, the growth of the care navigators, and that kind of role really coming together for organizations across the spectrum, often to target and manage based on payer program or specific bundled payments like CJR and others, to be able to manage these things. But it's often out of band as well and has their own interaction point with the patient. And then in order to measure anything and have analytics, often organizations are tied to their own EMRs, leverage claims in some cases to try to be a complement to the community clinical data. And what this ends up being is a number of different plates that are spinning from an IT perspective to try to manage the job at hand, which is I want to be able to manage patients and populations across my ATO, clinically integrated network, or HIE. And when we say manage, this is what the CIO, this is what the Chief Population Health Officer, this is what the COO, this is what the directors of IT, the directors of clinical applications, this is what the interface analysts and DBAs and the users all have to try to figure out, when is it that I'm supposed to do something for this patient to ensure that I'm doing the right thing for that patient at that point of time. And it's users and patients all coming together across these different ecosystems that is very, very difficult to manage. Many of these organizations are stuck. You saw and probably have seen that very few ACOs were successful. Folks taking on risk start very, very small, often with their employed population, or start to really dabble their toe in the water just to take in the low levels of risk across broader networks, 10, 20, 30, 50, 100,000 patients, but not necessarily take on the full actively managed risk across those populations, because this is the spaghetti soup of air traffic control of what's happening with the patients. It's very hard to solve, because when you're trying to say, what are my jobs to be done, I have to try to adapt. I'm being pulled onto the carpet, pulled onto the carpet for each one of these different areas. I'm part of an MSSP ACO, I'm part of value-based care. I want to drive better clinical outcomes, but my world looks like this. And so it's that stepwise point to try to say, I need to start small, to aim small, miss small, so that I can really target programs, target approaches that can drive these things together. It really is going and sort of across the two vertices of value of care delivered and degree of strategic transformation. We see some of these no regrets investments and strategy dependent investments that allow organizations really to target and identify where at in this curve do they want to start to make changes. We see physician alignment. We want to be able to strengthen that referral network, because this is something very, very powerful. We talk about interoperability. We talk about these building blocks, and how far you want to go with those building blocks of interoperability really lines up very clearly as to how deep or how advanced into the value-based care market that you want to deploy. So from an overall value perspective, as organizations want to go and manage total risk, I shouldn't say this is an end goal, because there's really no end goals in these things. Folks who have been doing this, like everybody that's joining us here today, knows that there's no real end. It's staged, it's focused, it's measured deployment and proaction, rather than being reactive, being proactive in order to align yourself for where you want to get to. You start by saying, I want to be able to focus on the areas that can make the greatest change with the lowest target approach. Minimizing practice substitutes, aligning incentives with independent physicians. Strengthening this referral network ensures that these organizations that are outside of your four walls are sending you people. It often is a very simplistic, I've used this a lot whenever talking about interoperability and population health, is it's an economics 101 equation. Revenue minus cost equals profit. Your revenue comes from the more patients that you get to see. Their cost is the people that are interacting with them, and you want to drive that profit up by having more patients come in your door, managing them more efficiently, and having the right people be able to manage them. So just that first net that you're attacking, that first net that you cast out, is building that referral network. And this changes frequently, but the last numbers that I saw was each referring physician from the ambulatory space into a healthcare system is worth roughly $1.2 million in revenue to that healthcare system. Because if they're sending their patients to an organization, if they feel, I don't want to say beholden, but if they feel tied, they feel valued, if they are sending their patients there, which means they're easy to do business with, that organization sees a great benefit from that level of engagement. Then we say we want to reduce costs. So we want to then be able to say, well, if I can target and engage with you as an organization, I want to ensure that that value that you're sending to the patients, I can tell you when something has already been done. I can tell you what you don't know about the patient without you asking for it. I want to benchmark you then in order to see who across my referral network, who across my affiliates are the right folks to take care of which patients. Who is it that's managing the plan? If you're part of that, and that goes into a little bit more advanced interaction, which is re-engineering your populations, re-engineering who's managing your population, appropriate utilization, ensure that those folks that are managing and are good at managing the patients with multiple comorbidities are managing to specific programs like CJR or hypertension, CHF, asthma, all of those areas that you can really target and identify. Your tools, your interoperability, your data, your interaction at the point of care is all one that actually makes it easy for them to ultimately manage the total patient population and be able to take reporting and identify the data and ensure and plan for any of the risks that may be involved across that entire population. If you start to aim small, start to build in the right programs, start to build in the right patient population, build in the right provider groups and right networks, it can build this stepping stone to being able to manage your total population. Not many folks are at this level. There's certain white papers out on folks who are, you can't see the air quotes I'm using, but they're managing their total population. But they're really trying to minimize the risks, trying to keep leakage minimal. They're trying to keep their referral network strong. And often, as you go through that, it's now that goes from sort of the strategic imperatives and the value is to then how do you adopt this? This is something that has proven very successful up across the ecosystem, is to identify the client's needs and desires. Often organizations are tackling that technical question. How can I be interoperable? Do you support FHIR? Do you support XDR? Do you support HL7? 2.x? How is it, if you just did this, if we had this technology or what have you, then it would work. And we've seen many, many use cases and client examples of our own even, where enabling the technology did not get the value that the client was asking for. Having access to all the information did not provide the value to what the client was requiring. And what we found is being able to enable additional teams, bookending and changing the way implementation methodologies, changing the way that the service delivery, changing the way that working with organizations is approached has proven to pay dividends in this arena. Being able to focus on client needs and desires right off the bat, being able to identify within population health, what is it that we need to do? Utilize that care in motion, utilize the ability to leverage the solutions, leverage the integration points that you have inside of your own network, identifying all of those avenues, all those users, as you think about all those avenues across that closed loop healthcare ecosystem that each one of you look to strive to be. Who are the actors that are involved? Who are the care navigators? Who are the registrars? Who are the PCPs? What is the process level of that interoperability? And then be able to say, does your data support the initiatives that you're looking to tackle? So during an implementation timeline, be able to step into this and say, Art, do you have the right access to the data? You saw earlier all that acronym soup of all the different interface types, all the different abilities or promises that are being built into the system. You need to ensure, does the underlying data, does it work? Because so many times organizations have been burned because once they had access to the data, they've relied on either themselves or a vendor or an analyst when none of those would help, when the originating data just didn't support what it is that they needed to do. So tackling this and understanding what your need and desire and driving it into the implementation to do data availability and quality checking is of paramount importance before you truly get into any kind of technical implementation. Being able to identify and have user acceptance testing tied into this and value adoption. I talked about that program on the slide previously as you're talking about what it is that you're looking to do, but having this value adoption process where the organization is involved and your vendor and whoever the key stakeholders are to identify what the requirements of the end user and the end acceptance testing are, and which ultimately drives to client success. Because then you can measure what is success, identify how to achieve success using the solutions that you have at hand, identifying that the data can fit within those solutions, implementing it, and then measuring that success afterwards. Identifying your return of investment really drives into the jobs to be done. These organizations, we saw the requirements of what it is that you're looking and targeting to do is to be able to manage those patients and populations. Some folks, as we talk, as I mentioned earlier, that measured approach, starting with maybe I just need to connect out to a regional, state, or national HIE. Maybe that's my level of interoperability. Maybe I need to just go from there, and that's my bare minimum. But maybe I'm a multi-specialty organization that actually is part of a broader clinically integrated network, and I'm starting to step into risk. How can I ensure that I'm actually managing this program appropriately? And at the end of the day, I don't wait till the fourth quarter or end of the third quarter to pull my data and see I'm way behind. I want to be able to target and create programs that are exposed at the very beginning as we negotiate through these programs, and then have a plan for adherence, adoption, management, governance, all throughout the even prior to the implementation process, so that we can implement it and then we can measure and stay in tune with the adoption of that utilization. So many times organizations step back from adoption, and we see this with interoperability. We see this with population health management. Getting to that want to, need to, should kind of deployment is something that requires constant vigilance to ensure that the clinicians, that the patients, everybody who actually controls how it is that the populations are being managed is actually utilizing the system in an efficient manner. The goal of this, what this really ends up being, is creating, we talk about populations, we talk about the interaction points, we talk about the overall goals of interoperability into population health management. But truly, what this becomes, we talk about populations because you're often doing a report on a diabetic or a COPD, or you're doing a PMPM report, or you're trying to identify who your risks, high-risk patients are, high utilizers, most costly patients, all these kinds of things. So it tends to be like a population approach and thought. But really what it tends to come down to, what it really comes down to is that true personalized medicine. Because each patient, each person goes into that as a member of that population, as a member of a population. So your goal is you're building up and creating interoperability. The real goal of it is to have that patient, have that person, have that clinician be able to have their notifications, have their record traverse your network with them. So what we see so much, and we talk about that ecosystem of those different systems, being able to have one level platform that can integrate with all of these different areas, so it becomes a living, breathing, adaptable ecosystem, enables that patient to traverse, be engaged with, have access to all of these various different ecosystems and be measured upon that. When you have this what we've seen from organizations that have this level of deployment that's out there, and there's some organizations that are actually measuring these things. There's reports coming out later this year for folks that are focusing in on interoperability platforms. This is one of those mechanisms that organizations are using to bridge that gap, to go from what is traditional interoperability, connecting out to HIEs or connecting system to system, but creating a process level of interoperability across all of those key stakeholders now and into the future. There's plenty of other things we could throw on this slide, but as they step into it, to reuse the slide earlier, it ultimately allows them to deliver this clinically sound ecosystem, having the entire patient be managed with data coming in from all the various different systems, being able to go and create this ecosystem of process management, and then adaption, being able to adapt to the changes in the patient, to the changes in the program, the changes of the data over time, so that you don't have to switch out entire IT infrastructure. It really becomes a future-proofing that creates this organizationally sound platform. This is what we see organizations as they start to look. Some folks call it my eye chart that I have with you as a health system, or I tend to think of it as a solar system. Often you have within your solar system, you have the folks that you're most closely aligned with. We talked about those referrers, with those referees that were out across your networks. Being able to have your health system integrate in a way that leaves you the benefit of value across all these outside influences that you either have to integrate with, leverage, build bridges to, or tightly align with, that creates an all-in approach to interoperability. Maybe I'll stop there. I want to say thank you for all of your time here today. See if there's any questions that are out there, if there's anything that we can tackle now, or if time is upon us, I'm happy to take some of these offline as a conversation as well.
Thank you so much, Mike, for that fantastic presentation. And like Mike said, we will now begin today's question and answer session. So please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll try to get through as many questions as we have time for. We've already had a few questions come through, so I'll go ahead and start with those. Mike, and the first question is, are there regulations pending that will accelerate the affordability of interoperability? Currently, it's a good idea, but comes with a high price tag.
Yeah, that's a reality for many folks who have gone. As you saw that diagram I showed earlier. As you start to go, the higher the value, it's typically much more, it's a bit more difficult to try to deploy for higher utilization, higher value of what interoperability is. And I'll tell you many times, so within some of the regulation and some of the abilities, things like common well and care quality, to try to hit that lowest barrier of interop, connecting out to those national entities, it often becomes a vendor question as to the cost to connect. If vendors, and I can only speak for myself and my company, my organization that I belong to, is we feel that that's a basic necessity, that to be a part of that healthcare economy, we don't charge for those level of connections for the broader interoperability national networks. The goal is to provide that value for the organizations, and then as the needs grow from there, leveraging the information in different ways. It becomes sort of phase level, which often becomes equating to cost of integration. When we say, what's your job to be done, we try to tie the value of the connection to the actual cost of the integration, so it's as minimized as possible. I can tell you from a regulation perspective, with TEFCA, that's coming out. It was a little left out of the CMS-ONC a little bit there, but things like care quality are covered under TEFCA and would be considered a QHIN, as they call it, a Qualified Healthcare Information Network. That would be something that would fit the need. It gives you this base level of interoperability. There's several other mechanisms for interop, things like direct messaging with CCDA, passing data from one point to another. I can tell you within our own system, our goals have been to get to 0 for interoperability connections and data access. But we see things like the 21st Century Cures, as well as TEFCA, and some other, what came out with MU3, reconciliation with direct messaging and CCDA, some of those mechanisms to keep the cost lower. Aim small, specific use cases that allow for specific solutions that don't break the bank.
Well, thank you so much, Mike, for breaking that down for all of us. And we've had a few more questions come through, so I'd love to go ahead and move on to the next one. And this question is, can you describe where community partnerships live in the vision that you are presenting?
Where community partnerships exist?
Yes, where community partnerships fit within this vision that you're presenting.
Yeah, absolutely. So that is, those community partnerships, often that's something that it needs to be a forethought. When we talk about population health, or we talk about interoperability, we talk about integration across these organizations, often it comes down to governance. I've seen this be, this has been big stumbling blocks within organizations. However, I've also seen it become great successes, where what were competitors, what were folks that didn't necessarily have a desire to work together, have come together under the right framework, created their own nonprofits, created their own data sharing agreements, all for the betterment of the community, come out to become much more integrated. For truly, as a member of one of those communities, I've seen it in action, seen the abilities where my children and myself and my wife go to our Y, or we go to our own health system, and they all have access to the right information. And that comes from having a sense of community ownership of that patient population, being able to have that base level of interaction, integration, having exposure and sharing of basic needs and requirements around an understanding that, hey, our patients are our patients, but they're also yours. Often what comes out is 50% of patient data exists in your system, and 50% of your patient's data exists in your neighbor's system. And having that sort of as a foundation, and having governance rules that organizations can step and feel a part of shaping, changing, and being involved in is a highly beneficial and required to being able to have a successful cross-community healthcare ecosystem.
Great, thank you so much for describing how those community partnerships fit in. And it looks like we have time for about one more question. And this person actually, Mike, they're asking if you could briefly repeat the last slide in your presentation and kind of go over the comments associated with the diagram as well. Sure,
absolutely. And I appreciate that, because I was looking at time and I was like, I needed to jump through it. So briefly, this is the solar system. And many organizations, whether or not they're a health system or they're a provider practice, there's often those organizations that exist. There's folks that they work with closely, and then there's folks that they work with that are in external bands. That could be their specialists that they always refer to. That could be the YMCA. That could be nutritionists. That could be folks that are out across your entire ecosystem. And whenever you have that closed loop platform put into place. You have connections to, one, capture information. What happened to your patients whenever they showed up there? How do I influence the workflow as my patients show up to my ambulatory, whether they're my own or they're my affiliates? As my patient goes out to the Y, how do I ensure that they actually went to the nutritionist program? As they go out to our urgent care, as they go out to the freestanding clinics that exist, as well as connecting out to their Fitbits, their Apple Health Kits, to their Wiggins scales, and they start to create all of these things. You need to have this level of a healthcare a closed loop system that can bring in the data from all of these things, that is in line with your insurance programs, in line with the regulation requirements, so that all of these things that are happening for your patients as they're going in and out of your network, all of these different providers of care, utilizers of care, all of them are actually leveraging what your initiatives are. So I showed that slide that was the one before this one, which was that closed loop healthcare system, goals, interventions, tasking, that ability to create gaps in care and identify what's happening for the patient. You want your efficiencies that you're managing inside of your own system to follow that patient as they go out across all of these different ecosystems, and shield yourself from all of those areas of disruption that are competitors to your own world, to everything that you have to do and manage for the patient. You need to ensure that you're ready in case someone shows up with the latest new wellness center, that there's new consumer app that actually tells patients to be managed a little differently, or telehealth that's happening out externally to your organization. You want to be able to have a program plan platform that can say, I already have access to all my information. I have a tightly integrated cross-organizational network that can adapt and manage and either work with or shield us from many of these external influences.
Great. Well, thank you so much, Mike, for breaking down that diagram for us once again. And that is all the time that we have for today, but I want to once again thank Mike for his excellent presentation and thank Allscripts for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.